Okay. Thank you once again, Brian, for joining us on this interview. I would like, first of all, uh, would like you to just briefly introduce yourself and tell us your name and maybe what you do, and
Sure.
also a little bit about where you were trained and how did your medical degree translate in the US.
hmm Yeah, I would be happy to. So very briefly, again, my name is Brian Chen. It's Brianchen. I'm currently finishing my advanced residency training in occupational and environmental medicine here at Johns Hopkins. Before that, I did a year of general surgery out in Long Island, New York, at a public net safety net hospital. I attended medical school in Taiwan, where I also had 1 year of residency training. So I had medical education and training both in a nationalized healthcare system, uh, as well as one that in the US that has primarily private, but also a mix of uh, public health insurance programs for the underserved.
Oh, interesting. It seems you trained in Taiwan and now you're in the US. So how did your training translate into US? Did you have to um, start practicing the moment you got into the US, or you were required to get an additional degree or take a test or an examination before practicing?
Right. Thank you for asking about that. So the process for what's called IMGs, which is short for International Medical Graduates, and it doesn't matter what your citizenship status, so to speak, is. You could be a U.S. citizen, so I am, or not. Everybody has to go through the same recertification pathway, and it also doesn't matter how many years of postgraduate residency training you have. You basically have to go back to this square one, which is the same pathway that all graduates of medical schools in the US have to come out of. And that is to take uh, at least the first two steps of the US medical licensing exam.
Mhm.
Those are the minimum licensing requirements to apply for residency training in the US. And then most states, so each state has a medical board that regulates how much training and experience you need in order to practice medicine in that state. If you don't have a full unrestricted medical license and you don't meet the requirements, most states have a mix of 1 to 3 years of postgraduate residency training in order to qualify, particularly for international graduates. It's a little bit more stringent. And it has to be postgraduate training that's ACGME accredited. So that's the American Council for Graduate Medical Education. So my prior residency training in Taiwan does not count towards that requirement.
Wow.
Yeah. So when I moved back to the US, back to Maryland, I actually could not practice clinically. Even after I had passed the minimum licensing requirements to apply for residency, I still didn't qualify for, as
Mm.
an international medical grad, qualify for in Maryland an unrestricted medical license. So the only way that I could continue to practice clinically is to get into a residency training program, fulfill the minimum requirements to at least get full licensure, and then take it from there. Uh, but generally, it's very difficult for you to have uh, like career growth and career potential without being at least what they call a board eligible or board certified physician. So, which means completing a residency program and being boarded in that specialty.
Wow, that's really insightful to know. Having done your residency in Taiwan and then coming back to the US to also do another residence, that's more for you to qualify to practice. I think it has its bad side. It also had its good side. It makes you more aware and then more knowledgeable in the area of your practice. I would like to ask you the second question. You work so closely with PCP, and how do you coordinate care with them?
So a lot of it is just back and forth between, for example, our occupational medicine clinic and the primary medicine clinic. And it can happen a number of ways. in my capacity as an occupational medicine physician, it depends if they have an underlying condition or something new that may impact their time at work. And so I basically coordinate to understand from the PCP, what's the workup then, what's the diagnosis, what's the treatment plan, what we're looking at, so that I can help formulate the transition plan specifically at work. Do accommodations need to be made? Do we need, wholesale time off from work? But really balance that part of it against the clinical picture of what's happening. Sometimes it will be what we call pre-placement exams. So particularly for public safety positions, there are certain fitness requirements. You think of like firefighters or police officers, or other, civil service workers. If there's any question about if they have any health issues that may impact their ability to safely do the job, I don't refer them for workup, but I could go back to the primary care provider and say, hey, these are my concerns about how this, acute or chronic condition might impact the job. I need some more information. Let's communicate about it. And so they'll provide the documentation to me that then I'll review and then make a final work recommendation to the employer. So in my experience, where the shortage comes in is in two ways. Most practices, so if they have a primary care provider, it's almost impossible to get follow-up appointments. There's a lot of delays in, follow-up or, just communicating with the office because everybody's so backed up. Even more challenging is if you are working with a worker population that doesn't have consistent primary care and you have to get them plugged in. That's very, very hard. Because, as I said, it's already hard enough for existing patients to get appointments, to find a practice that's established where they have openings and to start from scratch, and establish that primary care home. It can be very challenging for a lot of people.
Thank you so much for providing that context. I know you talked about shortage, but we'd like to know more about what are your thoughts on the shortage of healthcare workers, especially in Maryland, where we're focusing this work on, and then more specifically, the shortage of PCP. Has it affected care coordination within your experience?
Yeah, so my experience is limited to this occupational medicine piece in Maryland. I have my prior hospital training was in New York, where there also is a healthcare worker shortage, particularly after COVID. So I can speak a little bit to the general experiences there. But in Maryland, one of the challenges with the PCP shortage is, so particularly if there are fitness requirements for a job and somebody has uncontrolled high blood pressure or something, right? You have to send them back to their primary care to manage that. So what I see from this kind of adjacent perspective is people aren't getting good follow-up for it. In some cases, people aren't able to see their primary care, or probably are not seeing their primary care regularly, either because of scheduling issues. If you can't make an appointment, it's very hard to reschedule the next one. So stuff just gets bumped down the road, or they don't even have a primary care provider and it's very hard to get established. So sometimes I'm the one that's catching these conditions as a part of our, pre-placement physicals or periodic physicals and workups, where I'm like, I'm a little concerned about your cholesterol. You should take this back to your primary care provider. It doesn't impact your ability to do the job, but I, as a doctor, but it's not a seamless transition. You talk to patients, you counsel them. They're like, yes, I understand. But oftentimes they don't have, as I said, they don't have primary care. It's very hard to get appointments. And so you'll see people year on year, either we are catching it. This should be, originally caught, diagnosed, managed in the primary care setting. But because enough of those services are just not available enough, that you're seeing people catch it in other ways. I know that in urgent care, in emergency rooms, sometimes, you catch people who have these chronic conditions. You're like, you don't know you have diabetes because based on your urine dipstick here, it looks like you have, like raging diabetes, I should probably get that checked out. I know that happened a lot when I was in New York, particularly. So I did a year of general surgery training, and oftentimes, you discharge people out of the hospital and they have to coordinate with their primary care, but so many people didn't. Um, or
Oh,
they would come in with a lot of underlying conditions, right? Because it was a major trauma center, so people get into an accident and stuff like that, and they'd come in and be like, as a part of our admission workup, you, sir, have diabetes. And it clearly looked longstanding because this level of diabetes doesn't happen overnight, but they had no idea because they don't have primary care.
wow. Thank you so much, Brian,
Mm-hmm.
for providing that context. I would like to ask you in terms of what do you think? I mean, with your experience in New York, what do you think we can address and effectively manage PCP shortage, especially in the Maryland? I assume
Yeah, so
you're a policy maker, and then you need to take a decision.
yeah, so there are a couple of ways to do it, right? I think one of the
Okay.
overall, I think health systems and also uh, like state healthcare provider sort of regular licensing boards have tried to boost scope of practice for NPs and PAs to kind of fill this gap. Because a lot of the primary care is not so acute. It doesn't require such a high level of or aggressive level of clinical intervention, right? So there have been, movement in that area. They try to boost recruitment to these programs as well as the MD programs. One of the big problems is the availability of residency slots, and that's funded at the federal level. So that's where the key limitation is. State policy isn't going to drastically influence that. Some of the suggestions that I think, there are a lot of highly qualified international grads who are not currently in clinical practice. There are a handful of states that have done this type of uh, like limited medical license, or I forget what it's called. I think the state of Missouri has one. I'm blanking on what it's called at the time. Uh, but you are not a fully unrestricted uh, like medical practitioner. You still have to practice under supervision to a certain degree, but you can engage in clinical practice. So I think creating some kind of regulatory framework that brings back the so-called general practitioner. So probably in the 1960s and 70s in the US, most primary care doctors didn't do a full like 3 or 4 year residency. They did med school, they did 1 or 2 years of general practice training, and then they were, community healthcare providers. In the 70s, there started to be a switch, right? So now you have people who finish family medicine residency, who do primary care or general internal medicine residency, and that takes 3 to 4 years, and there are limited slots, right? So if you create a framework that allows you to leverage this existing resource of already trained individuals uh, who are capable of practicing, and you basically open the door, right? There's an artificial door that's closed, or there's just this wall there. If you open up a pathway to allow them to be clinically engaged, you can leverage that skill and that pool that's already there. I think they looked at this a year or two ago in Maryland. There's not a huge number of like international grads that would qualify in Maryland. But on the flip side, there aren't a lot of opportunities nationwide for those who may want to do this. So it would draw it would be a talent draw to Maryland. So you get more people to move to Maryland who want to remain clinically active. The other thing is most med students do graduate. American medical graduates do go on to do residency in some specialty and move on, but not everybody. And I don't have hard numbers on this, but just from conversation with medical students and other residency trainees, there are people who, for personal or other professional goals, like reasons, may not want to do a full residency and invest all of that time, but still want to be clinically active. And so this sort of intermediate practice area would allow them to do that. And so again, you're leveraging resources, providing more opportunities. So that's kind of my pipe dream. I have no idea how the nuts and bolts of this would work, but that's an
Oh,
idea.
that's yeah. Thank you so much. I mean, it's what you mentioned sort of relate to it. One of the points that we made, some of the suggestion we made, with regards to in regards to the training pathway, especially for international uh, students who want to practice. Let's just deep down a bit further. I know you've mentioned this, but I would like to know how do you think this training pathway can be made more efficient? I know you talked about maybe, I mean, designing a framework that may sort of uh, you know shorten the process. But I mean, going deeper, what would you, or maybe in a few words, what would you say the training pathway, what can be done in the training pathway to make it more efficient?
I think at the end of the day, it's really opening up, it's a numbers game. There is a significant bottleneck and restriction on the number of
Mm,
people that you can funnel through residency programs. And even for American medical graduates who they need at least 1 year of postgraduate training in most states uh, to apply for their unrestricted medical license. So to be able to practice independently. I think by creating, I don't know what to call it, perhaps a second tier or temporary uh, licensing option, right?
mm,
Would allow for people to enter into particularly primary care clinical practice, and there are different ways to do it. So for example, Texas doesn't have that secondary license, but they will fast. So one of my friends got her license fast tracked if you're going to practice in a high needs area. So that's the thing. It's like if you already have, you're looking to do primary care, for example, in a part of Maryland that is underserved, say the Eastern Shore, um, and you're applying for this secondary license, that it can be fast tracked, that it can give you an opportunity to practice. That's how I would like to see it. Just different ways of putting people who are already clinically trained and otherwise meet basic licensing requirements. So I'm saying is like for an international medical graduate that you're ECFMG certified, which means you've passed your fundamental licensing exams, but you're not at the level of getting your full unrestricted state license. There's a gap there, right? So how to build kind of a bridge? Well, either a bridge or just a connection to bring that currently latent clinical training into practice. And it may not be, there's contention about, because it doesn't lead necessarily to full licensure, it doesn't necessarily lead to residency. But I think even though it long term for some people it might be kind of a limbo state, which means there could be turnover in this pool, it still allows the state, for example, to draw on that latent training that's already there and activate it.
mm.
The
Insightful.
questions on the other side would be whether this pathway is a bridge to full licensure, and it might be, because there are some boards when it comes to specialty training that have so-called practice pathways. And so you could potentially do a practice pathway to full licensure, right?
Mhm.
So if you do like 4 years of this primary care, like secondary under the secondary license, and you've had a very good track record, whatever, blah blah blah. They set out criteria. Perhaps you could then convert that into a full license. You wouldn't be board certified in any specialty, but you would continue to be able to be a general sort of primary care provider, right?
Well,
And that may be
thank
an
you so.
option for quite a number of people.
Okay. Yeah. Thank you so much, Brian, for the insightful, information you're sharing with me at this moment. The next I would like to ask and get your opinion is you mentioned about the fast tracking licensing, as one of the ways. But I mean, do you foresee any challenges or obstacles with improving the shortage of healthcare worker, especially for PCPs?
Yeah, so the healthcare worker shortage is very broad, right? Because it includes both medical providers, so like medical doctors. It includes nurses. It includes other, uh, you know, licensed professional nurses, medical assistants, things like that. So up and down the chain, you're finding it very hard to fill these roles, and it puts a squeeze on healthcare delivery day to day. So even in occupational medicine clinics, they're finding hard times uh, to fill medical assistant roles, and because we're at the point where there's so many facets of care that everybody contributes a different part of their expertise to that, right? So medical assistants do, um, for example, part of it is administrative, part of it is basic, right? You know, prepping the patient, getting vitals, signs, things like that. But these are all part of the rhythm of getting the patient ready to be seen, getting the patient seen, getting the patient out processed. In hospitals, for example, like the lack of nurses means that there's a lot, the levels of work and the levels of stress are higher for bedside nursing care.
Mhm.
And the way to address those challenges are going to be a little bit different. Uh, but in terms of the primary care shortage, one of the big challenges to like this idea that I've had is how do you interact with the other primary healthcare provider types, right? Because they're, for lack of a better term, sometimes feels like there's a turf war between, medical doctors and NPs and PAs, when in reality, when you look at how clinical teams operate, there isn't. Everybody is very complementary,
Mhm.
and can set up to work alongside each other very well, diversifying, particularly our primary care provider workforce in terms of how they're trained, is an advantage. But I think one of the challenges there is a lot of people may see it as a turf war, and so there's a question of who is going to have what slice of the pie, right? And that's more of a communication and cooperation challenge. I
Mhm.
think once everybody gets on the same page and has a cohesive like coalition type approach to it, um, you may be you may find yourself more easily able to overcome that challenge. But I think it's a big one, where people may perceive themselves to be adversarial because it's like, oh, we're going to add another. And this also, from a practical standpoint, does add another layer of complexity. So because you're creating kind of a new framework, right? Health systems, clinics, hospitals will have to figure out how to credential these people. So there's a lot of growing pains involved. How do you credential them? How do they bill? How do they get compensated? Things like that. How will malpractice insurance work? There's a lot of other moving parts that need to be addressed, and you have to be systematic in the approach of putting this framework together. It's not just, well, we're going to license some more people to see patients. It's not that simple. So I think being mindful of that's one of the other challenges is the implementation.
Thank you. As a way of rounding up, I know you've mentioned some of the strategy in the course of your intervention, but I mean, again, from your experience working in New York, are there strategies that Maryland can take away from other states to sort of, solve the problem of PCP shortage?
Um, I don't know that New York is doing anything particularly different. Um,
Okay, would you say the problem is more in terms of shortage, more in New York compared to Maryland?
that one's hard because I don't have hard numbers. I just kind of have an impression. It was a little
Mhm.
bit skewed because I was in the metro New York City area, which
Oh, okay.
tends to have a higher concentration of healthcare providers. Uh, for most people who didn't have primary care, it wasn't, I mean, there was still a shortage there, but it wasn't as if, you go to more rural towns and things like that. Uh, and there are definitely, whole towns that don't have a primary care provider, within a certain radius. I don't have the data on that. My impression is there's other barriers of access to primary care in the metro New York region. And part of it is, that there isn't enough providers for the amount of population that needs primary care, right? I don't know which state has it worse because I don't have the numbers off the top of my head. I know that we run into similar challenges of getting connected back to primary care, getting primary care follow up for our patients in very different settings, right? So I know that there is an overall trend that you can see uh, from the front lines of healthcare.
Yeah, thank you so much. I think one of the states, according to the little research we've done, is California and maybe Florida. And some other states have began to look into strengthening pathways, sort of provide some interventions in the area of pipeline, and then training pathways. And that has been proven to show little progress. Do you, in your thinking, I know you've mentioned it, but just for the word of record, do you think that is also key to bridging this gap of healthcare workforce in Maryland?
Yeah, I think the first step is to do like a thorough needs assessment to see where your gaps in the healthcare workforce are, specifically what are those gaps. Otherwise, your interventions aren't going to be very tailored to it, right?
Mhm.
Are you having a shortage of primary care providers? And what types of providers, right? That's a big question that you have to answer because if you're just increasing the number of medical graduates, that singular policy alone, let's say the University of Maryland boosts funding for the School of Medicine, they increase their class size, but these people graduate, there's the same number of residency slots, they're not able to get in. And maybe it could very well be that you don't need to boost the number of medical graduates, that there are enough NPs and PAs that could reasonably cover that primary care need. So you have to look at where your resources are and where your gaps are and whether you can appropriately leverage them. And then from there, you develop your policy intervention, right? It could very well be that it's not just a lack of providers, but then once you shore up the number of providers, there's not enough funding to deliver those services, right? Or there are other barriers in delivering or accessing those services. So you really have to kind of zoom out and take the big picture when you're looking at this. I think it's definitely a piece of the puzzle, increasing the just raw number of providers. But a lot of it also has to do with, and you'll hear this from primary care providers and primary care clinics that uh, for the ones who do accept insurance, that compensation has been going down. And so in order to keep revenues up, you you see more patients for a shorter amount of time, right? It becomes almost assembly line medicine, which leads to healthcare provider burnout. You also have issues of, for federally qualified health centers, the way that they're funded, they have to be appropriated. So every year they have to fight for funding, right? And so if we had more consistent, more dedicated funding, it would also be able, they could plan long-term staffing needs, a lot more effectively. So, there are a couple of other, and so the state may be able to step in and sort of smooth out that funding, for example, right? That's another strategy that's unrelated to just the numbers of providers.
Wow. Thank you so very much, Brian. It has been an insightful conversation. I didn't know we were again going to gather as much information as this. Thank you. We really appreciate it. I would stop the recording because we're done with the interview now. Thank